So what is the big deal about hearing and aging, or hearing at all, from the population health perspective?
It's a disability, and it's a...
On this episode, Dr. Dan Osterweil sits down with Dr. Joshua Chodosh. They're talking about hearing loss and aging, and what's being done in the field to aid those slowly disappearing from conversations they can no longer follow.
It's a functional disability, and it's a social disability.
She was a petite lady, very hard of hearing, and she was coming into the clinic and couldn't hear a word of what I was asking.
If you're in the group that's 80 years and older, you probably have a 75 to 80% probability of having significant enough hearing loss that you would benefit. Look, when you go to a doctor and you leave the doctor's office, it's hard enough to remember what that person just said to you. From the standpoint of a patient, that's usually kind of a monumental experience, right?
Yeah.
There's a lot of emotion. What are they going to find? What are they going to tell me to do? Am I going to feel differently about myself? Until very recently, there are some very new developments in the hearing aid industry that is incorporating AI. And this is a disruptive technology. This is a new innovation in hearing healthcare.
Hello, good afternoon. I am Dan Osterweil, co-director of the intensive course in geriatric medicine and board review at UCLA. And it's a great pleasure to have this conversation with Dr. Joshua Chodosh, a good friend and geriatrician that will talk to us about hearing loss and aging.
Thanks so much. I'm happy to be here. It's great to have this opportunity to talk with you, Dan. So I am a clinical geriatrician and health services researcher here at NYU Langone Healthcare System in the Grossman School of Medicine, where I'm a professor of medicine and population health, and I also direct our division of geriatric medicine and palliative care.
We'll dispose of formalities, and from now on I won't call you Dr. Chodosh, but rather Josh, as we have been for the last zillion years. And it's really great that you could make the time to share with us some of your pearls of wisdom on this topic, which has been an interest of mine for many, many years, and now even more as I get older into my later years. And I won't use any jokes here to demonstrate the issues of hearing, but as far as you are concerned, and I see that among your responsibilities actually being a professor of population health. So what is the big deal about hearing and aging, or hearing at all, from the population health perspective?
It's an enormous deal on so many fronts. First, it's incredible level of prevalence. We're really talking about age-related hearing loss, not all hearing loss, not congenital hearing loss, which is a worldwide problem, but age-related hearing loss. If you're in the group that's 80 years and older, you probably have a 75 to 80% probability of having significant enough hearing loss that you would benefit from some adaptive device. And what's equally important about that is that if you're not benefiting, that means that your hearing loss has impacted your ability to communicate, your ability to interact with your peers, with your family, reliably, with clear information, that you're enjoying your relationships to their fullest because your communication is easiest. And so it's a disability. It's a disability, and it's a functional disability, and it's a social disability.
So why, since Medicare has kind of put out this annual wellness visit and insisted that during the regular encounters people ask whether people fell, or people, all those questions that we have worked very hard to introduce into mainstream, why nobody ask about hearing?
They should. I think part of the problem is if you're a Medicare insured person, you can go to see an audiologist. Medicare will cover that. But then what? Now, if you're going to qualify for a pair of hearing aids, you could be, easily on the cheaper level, $3,000, but maybe as much as $6,000 out of pocket cost for a pair of hearing aids. If you have Medicare managed care, those costs will often be less because more and more plans are offering a benefit, but most of those plans that I'm aware of don't cover the full cost of hearing aids. And so it's a big expense. And hearing aids, of course, aren't the only answer, but I think too often audiologists don't necessarily offer other strategies, and they should, because there are many things that one can do if they have hearing loss, not just hearing aids.
Would you like to expand on that a little bit?
Sure. So, it depends on your level of hearing loss, but if your hearing loss is in the mild range, you might want to use some sort of strategy that's situational. You might not need your hearing to be perfect all the time, but if you're going to do a particular thing, you might want to have an advantage to help hear more easily. And so, for example, earbuds that are connected to a device, not to be, promote any sort of commercial entity here, but there is software and there are programs and devices that if you're wearing the usual earbuds that we use to listen to music or even a phone call, you could use your phone as a directional microphone to listen. The other thing that is true now I think pretty much across the board of smartphones is closed captioning, which is really helpful and quite accurate, to pick up what somebody is saying and turn it into visible words on a screen for you. That's another strategy. And also just teaching you about strategies. Don't try to have a conversation in a crowded room with a lot of noise. If you're going to go out to eat somewhere, think about the environment you're going out to eat in so that maybe you can enjoy that conversation and not feel frustrated because the acoustics are so bad.
So let me
Just one example.
Sorry, so let me actually interject here with a question. Do you suggest that if I'm hard of hearing and I have a phone and earbuds, and I go to a restaurant with you, that I'll put my phone in the middle of the table and I can benefit from that, or the background noise will kill it?
I think you'll still pick up the background noise. So I don't think necessarily it's a great thing in a noisy environment. But honestly, neither are hearing aids. Until very recently, there are some very new developments in the hearing aid industry that is incorporating AI. And I know of one device in particular. I have not tried it myself yet, but I will. Because it sounds extraordinary, because it really does address the signal noise issue. It does filter out background noise. There are AI strategies now where it can recognize the voice of the person that you're looking at and filter out the other noise. And the people that I know in particular who are involved in this company and are promoting this are really ecstatic about this. This is a disruptive technology. This is a new innovation in hearing healthcare.
Interesting, because a friend of ours just said that her best friend is flying to New York because she heard about it, and she has to go in person because nobody else provides
That's
those
correct,
technologies.
and I bet I know where she's going. So again, I'm not here to advertise, and people write in all kinds of questions about this. I'm not on their board. I don't. So and even if I were, I wouldn't use this to do a commercial promotion. But honestly, and I haven't tried them myself. So this is right now I think this is a little bit along the lines of hearsay, but I think I can tell you that what's happened, and they're not the only ones. This is not an exclusive technology, but they are engineers, and then they looked for audiologists to run their storefront. But they're engineers, and they use that engineering background to build a better mousetrap.
Sounds very, very intriguing. Let me ask you, since you've been flying all over the world and talking about hearing loss and other things, have you picked up anything that Europe or Asia is a little more advanced in its approach to dealing with hearing loss than we're here in the States?
I don't, that's a good question. And first, it sounds like I'm a world traveler. I've gone a few places around the world, but certainly not all over the world. And I think that I once was involved in a conference and we had people, we had speaker from Australia. We had someone else who I think was originally from France, someone from Canada, and I don't have the sense that that things are very different, except that I think that there's perhaps because of the more socially minded and different healthcare systems that access may be a different issue in some of these other countries, as may be cost. Because here, as I mentioned, these devices are, can be extraordinarily expensive.
And what about those loops that in auditoriums and in public
Yeah, well, the loops
places?
are great. Those are FM frequency, wired into those rooms, but usually you either if somebody was going to a theater event or something like that, they would get a headset, and that headset would hook into that loop. But if you had a pair of hearing aids, and usually if you have a pair of hearing aids, you've got an app on your smartphone, and you could then connect to that loop from your hearing aids.
Yeah.
And so one of the nice things about hearing aids, I think, and I'm not an overall promoter of hearing aids. I think they're not for everyone, and they often aren't adequate. But one of the best things about hearing aids, at least as a burgeoning technology, is built-in Bluetooth, so that you can program these directly into your phone. And so when you get a phone call, that you have to pull your hearing aids out, and you have to first put in an earbud if you want to listen that way. But you can listen directly from your phone. I will tell you that even in some of the better hearing aids that I've tried, the Bluetooth is nowhere near perfect.
Yeah.
And I know that Bluetooth as a technology is improving every day. So that's going to get better, and I think it's going to get better really fast.
Let's switch gears now to an area that has a lot of myth and misconceptions, and this is the relationship of hearing and cognitive impairment. Does hearing is one of the risk factors for dementia?
Well, if you listen to what a lot of people are saying, you think it might be. I think for a long time in the literature, from an epidemiologic standpoint, there have been strong associations between hearing loss and cognitive impairment. But I think we have to think about the company that it keeps. I don't think there's much question that if you have poor hearing and you're cognitively tested, and that hearing has not been properly addressed, you're going to do poorly on those cognitive tests. So already that's one instance. I think the other thing that happens is when you have hearing loss, very often, because it's harder to interact with other people, because of the stigma of hearing loss, you may self-isolate. You've had one too many experiences where people got upset with you. How many times do I have to repeat myself? And that people conflate poor hearing with poor cognition, when in fact they're two very different functions. And so people socially isolate themselves, and we know that social isolation in and of itself has some very deleterious health effects, one of which may be cognitive impairment. And then lastly, I think that we underappreciate the plasticity of brains, and when you don't use certain parts of your brain, those parts, particularly as you get older, has greater likelihood of having atrophy. So that even some of the studies now that are looking at hearing correction and brain morphology and respective atrophy in specific brain regions may not be the kind of atrophy that we see from inflammatory states, where there's actually neuronal cell death, but it might be the atrophy of lesser use. Just like we see other areas where people have really used very specific cognitive functions where they may have more development in those brain areas.
So it's sort of use it or lose it type of thing?
Maybe to some extent. I mean, certainly if you took a group of people and you socially isolate them for 6 months, and then you give them a series of cognitive tests. Nobody's ever done this study, of course, but I would hazard to say that they probably will do more poorly. We know, at least anecdotally with our patients, when they are then engaged with their family, when they have more to do every day, they do better. We see it. they're more alert, they're more engaged, they're smarter, they're more capable from a cognitive standpoint than if they haven't, than if they've been very isolated and if you will understimulated.
So what would you recommend the family or with the loved one who have mild to moderate hearing loss that have also significant cognitive impairment as far as amplification?
Well, there even more so, I worry because we just made that cognitive function a whole lot worse. Because not only did I not, remember what we talked about 10 minutes ago, but I never had the opportunity to really encode the information. And there's an important piece there that I think people don't think about, which has to do with cognitive load and cognitive bandwidth. If I'm working really hard, if let's say I'm actually engaged, too often those folks are checking out. It's just too frustrating. I'm going to sit there, I'm going to smile, I'm going to nod my head, but I'm not going to clarify what you're saying because it's too frustrating, it's embarrassing, so I'll just kind of play along. That's what some of us would call checking out. And so if you're working really hard, alternatively, you've not checked out and you're working really hard to understand what somebody is saying, you don't have the same ability to encode the information that you've been given because you're really thinking mostly about the words and did you get the word rather than in a more relaxed way the concept that you're now thinking about and working with and encoding it in your normal conversational patterns so that you actually have something later to retrieve. If you don't encode the information, you sure can't retrieve it. So I think that's an area where somebody with cognitive impairment, whether they have cognitive impairment or not, might benefit. But there are other ways too that we don't well educate families. One is when you're having conversations, reducing the background noise, making sure that person can actually see you. Maybe they have visual impairment too. Making sure that the area is well lit, that your face is well lit, because all of us use facial expression and, more importantly, lip reading to understand, to fill in the gaps where we don't quite hear things perfectly. None of us hear everything perfectly because none of us probably speak with perfect diction unless we are really trying and emphasizing and trying to speak that way. So that becomes a potential piece that one can do behaviorally that may improve one's communication ability and mitigate some of the hearing loss. And then it's also, how do you talk to somebody? Are you like super fast talker and you're mumbling and you're, blah, blah, blah. And of course you just made it harder for somebody to understand you. It'll be hard for anyone to understand you, but now it's doubly hard for somebody with hearing loss. So families being aware of this is really important. And then we haven't talked about this, Dan, but another I think very useful strategy that we've had a lot of traction with is the use of other kinds of amplification devices. People sometimes call these pocket talkers because it's usually something that can sit in your pocket and it's a headset that's hardwired to a device. It could be earbuds or it could be a headset. I think the advantage to a headset is the noise cancellation and the directional microphone in that device can make an enormous difference because you can take it on and put it on and take it off whenever you want. You don't have to have the same level of dexterity to manipulate, as you might with a small pair of hearing aids. They can be a little harder to get in or take out if you're not sure just how to do it. So that can be a very useful device, and they come with a long cord. So imagine that you're sitting on your couch, but the television is 20 feet away. You could move that microphone closer to the television. You're still listening, and you've got directed sound, and that can make an enormous advantage, enormous benefit for people who have mild to moderate hearing loss.
That's a great point. I think I heard that you did some work on utilization of emergency room services for people who have hearing loss. Can you comment of?
Yeah, we did, and we're still doing it. We're in now 4 emergency departments across the country in the VA system, hoping to actually do this in a larger pragmatic trial in the non-VA system. But basically, that's a project that screens individuals for hearing loss using a verbal survey, a question and answer, simple question and answer survey. And if people meet criteria, which is self-reported difficulty with hearing, then they're offered one of these hearing amplifiers to use during their emergency department visit. We did this in a randomized controlled trial as our first foray into this work. And so we randomized people to get these pocket talkers either at the beginning of their visit or at the end of their visit. Everybody got one because we wanted to be able to interview them at the end of their visit and not have hearing loss be an impediment to that survey. And the kinds of things that we found were not only were people reporting that the listening was easier, and that there was a greater sense of enjoyment or satisfaction with their visit, but we also heard the same thing from the healthcare side, from the physicians and other staff, that they loved it when these patients actually could hear them more easily. Their work was easier. But then perhaps most importantly is we saw a huge difference in people expressing that they knew what was wrong with them when they left the emergency department, what diagnosis they had. Imagine maybe only a third of the time, 30% of the time, somebody asks you, what did the doctor say was wrong with you, that you actually knew? Versus, 3/4 or, higher numbers of people who left the emergency department who could say what was wrong with them as a result of having one of these amplifiers. And then the last thing that we had as a signal, this was not powered for this outcome, and we've done additional work now that we have not analyzed yet with greater numbers, and hopefully we'll have enough power to detect a difference, is that we saw a threefold difference in 3-day emergency department returns. So that if you didn't have one of these amplifiers, you were 3 times more likely to be back in that emergency department. It was 9% versus 3% were back in 3 days.
Wow.
9% for those who didn't have the pocket talker, and 3% for those who did. So that's a pretty, and again, too small to be statistically significant. I think we had 160 patients roughly in that particular trial. It was never powered to do that. It was pilot work, so we really weren't talking about statistical significance anyway. But it's pretty hard to ignore those differences.
It makes perfect sense. Now, were you successful in having those pocket talkers or similar introduced into your own clinical setting? So every clinician has those in case they encounter somebody who is hard of hearing?
To a fair degree, we certainly use these in our ambulatory clinics, I think, quite well when people remember to do it. Because that's the other piece, is that I think we have not yet built into our clinical decision supports the proper nudges and even the proper screening to know that this is a person with hearing loss, and you should be using some sort of a amplification strategy if they don't have hearing aids and those hearing aids aren't working so well. But we do that. I think on the inpatient side, I think they're readily available. Again, when people think of it, usually, in my experience, it often requires a geriatric consult to think of it, and then they get one of those amplification devices. We need to change that, and I think we'll get there, but there's a number of steps I think that we have to get into place to make that a reality.
What you just said reminds me a story from my time with Sage, where I had a couple, came from Florida. She was a petite lady, very hard of hearing, and her husband had moderate degree of dementia, but he was very active and spunky. And she was coming into the clinic and couldn't hear a word of what I was asking. I say, "How is Saul doing?" And she says, "What?" And twice he said it, and then Saul says, "He is asking you, how am I doing?" So that made an impact on her, and she agreed to get one of those hearing aids with this big remote that she was able to put on her belt and adjust it. But whenever she was coming to the clinic, she was adjusting it to the lowest. So it was always a challenge, but it's really a fascinating challenge. Yeah. Anything else that would like to?
What we haven't talked about are cochlear implants,
Yeah.
and and again, because they're not utilized enough, I think, and those are really the best strategy for folks who have a higher level of moderate to, most importantly, severe hearing loss, where amplification isn't going to fix the problem. And one of the I have a colleague who's a skull-based surgeon, otolaryngologist, who does a lot of cochlear implants, and he's taught me that what happens when you raise the level of amplification too high, you distort the sound. So that's a technological problem, which I think may have been fixed to some degree by these new hearing aids, and by this AI incorporation, this higher level of engineering. But even so, there are instances where you've got to get to the hair cells. You've got to get to the cochlea to stimulate it directly to the cochlea, because it isn't going to work otherwise. And I know from clinical experience, this has made a huge difference in the quality of life for patients. It does require a learning curve when they're given one of these. I think a lot of people shied away from this because it was like brain surgery. And in fact, now we do these as same-day surgeries. It does not require anesthesia, and it's very well tolerated. And there are a whole lot more people who are sticking with their hearing aids, maybe being frustrated with them, constantly going back to an audiologist to have them adjusted, when in fact what they really need is a different strategy, and in this case, perhaps a cochlear implant. One of the things that is not done typically in the audiology suite is word recognition. A lot of audiologists will use what's called a real ear, which is basically based on your audiogram. They'll take those hearing aids and using computer adjustments, set them to the proper frequencies to match your audiogram, and then that should give you good listening ability, right? But what's not being tested is a sort of a real-world application, which is when you have the hearing aids in, and I say specific words to you, what is your hearing accuracy? Because I think in too many instances you'll find that they're not recognizing even 50% of the words that are being spoken.
Yeah.
Well, that's a hearing aid that's not adequate for you.
Now, as far as the adjustment to cochlear implants, do you have an idea of what are the highlights of the most challenging parts in this, what you call learning curve?
I mean, I think it's a different sound to get used to. And so I think it takes that I think one has to set proper expectations so that when you first, attach to the external device and you're listening to this noise, let's call it noise, that you don't expect it to be what you would normally expect to hear, and not being a cochlear implant user myself, it'd be hard for me to explain what that is, but I think the sound has a different quality.
Yeah.
And that quality takes some getting used to.
Yeah, a friend of mine who is also a neighbor and a neurologist had a cochlear implant, and he said that he's an avid music listener, and listening to the orchestra and listening to things that he knew, the tunes, was extremely challenging. And it took a while to get really.
What did he get there?
I think he got there. It took him about 6 months.
Yeah, 6 months is about what I'm accustomed to hearing.
Yeah.
In terms of the strategy for this. But just imagine someone that couldn't communicate at all, other than closed captioning or sign language or whatever else, and now can actually communicate and communicate pretty well.
Yeah.
That's like an enormous game changer for someone in the quality of their life.
Now, not to make it look ominous, but when a physician doesn't pay attention to hearing, what injustice or what are we missing as far as the patient is concerned?
What's the physician missing?
If the physician doesn't pay attention to hearing, it's like, if you miss blood pressure checking on a patient, there's a risk there. There is what kind of risk he is exposing the patient to if he doesn't pay attention to that?
Well, as much as a wasted visit. because depending on how probing the questions are, the physician might get socially acceptable answers without necessarily a lot of content, or the wrong answer because the question was misunderstood because it wasn't heard properly, because a couple of words were missed, and they still answered the question because they got some of it, and less attention, because again, it's about this. Look, when you go to a doctor and you leave the doctor's office, it's hard enough to remember what that person just said to you, because that, from a standpoint of a patient, that's usually kind of a monumental experience, right?
Yeah.
There's a lot, I think physicians don't realize there's a lot of emotion that's happening for many patients when they walk in to see
I
a
bet
physician.
you.
It's not just a walk in the park.
Absolutely.
It's a big, for patients, most patients, probably at any age, it's a big deal, right? What are they going to find? What are they going to tell me to do? Am I going to feel differently about myself after this visit because now I'm going to walk out with a different diagnosis or a new diagnosis, right? All those things
Yeah.
are operating. And now I'm sitting there explaining to you what's going on, and I'm giving you 3 recommendations or 5 recommendations or whatever it is. If I'm really good, maybe those recommendations are being written down, so that will help. But we don't really have any opportunity to clarify, even if you understood what those recommendations were. Maybe I have to adjust them because you're going to say, I don't know how to do that, or I can't do that.
Right.
But I'm not getting that feedback. So it's a wholly inadequate visit. And AI is not going to fix that. The AI will help a little bit. We now have in our institution, we have what's called ambient AI, and I just heard a presentation yesterday that was kind of jaw dropping, where the ambient AI will produce not just the note, but it will take out of that note the specific
Yeah.
patient-specific recommendations and put it into lay language, and provide and pick anything that was an order that was given that maybe the physician didn't include in whatever they might have done if they handed them a piece of paper with or printed something, here's what I want you to do. So I think that's a game changer. But if you're a patient that doesn't hear well, and now you got this, unless you can look at this and now spend the next 5 to 10 minutes that you don't have asking questions about those things, because now you understand because you're looking at them, assuming you've got reasonable vision, you're gonna miss out on a lot, and so that visit has the risk of being far less effective. And some of those things could be pretty important, like making sure you show up for that examination, or making sure you go to the pharmacy to pick up a medication that was ordered for you, or that you take it in a certain way, all those things, right? Or certain red flag symptoms to look for, to make a phone call, right?
Those are great points. And actually, when you look at the protocols or the workflow in clinics, this handout after visits, summary is handed, in the window when you leave.
Foot out the door.
So there is really no opportunity to
Right.
talk
No, that's
about
right.
it. So that's a food for thought too.
It's the same issue, right?
Yeah.
It's the same
Yeah.
issue.
So I know, just for the benefit of the listeners, that you are going to speak at our intensive course this coming fall, and I'm sure that you are going to touch upon many other points that we have not touched upon. And I really appreciated this chat because I think it gives an opportunity to explore an area that is, I think, neglected. And I remember that you talked about recommendations of the Institute of Medicine at the time about hearing and hearing aids, and the fact that hearing aids right now you can get without prescription in certain points. What do you think what's the potential impact on that on hearing health?
I think hearing aids that you can buy over the counter are probably helpful for a certain slice of society. Because if you look at those inserts, if you look at what's being provided, they're not, a couple of things. One is you may not fully understand how best to use them. There's still the issue of, can I manipulate this? Will it fit properly? What's my manual dexterity? Do some considerations need to be made for that? And also you can buy, I believe, programmable hearing aids now, where you do an online test, and that hearing aid is then programmed to your online audiogram. But it cannot be. I mean, it's never going to be as accurate. And my worry is that people are going to buy these things, and if you think, right now the statistics that I know are about 3 out of every 7 people who are prescribed hearing aids wear them. Okay, that's less than 50%, and you just spent a lot of money to have something adorn your desk drawer, if you don't lose it, if you don't put it away somewhere and now you can't find it because you're not a regular user, and now you're going to spend, it's also out of pocket, but it might be as much as, I don't know what they're going now, but maybe $600-800 for over-the-counter pair of hearing aids.
Even more.
And so if you're going to do that, I know if you go through even the real ear process and the audiogram, etc., when you fit those hearing aids, the first time you fit, they're not necessarily correct for you. The sound audibility is not necessarily exactly right for you, and that should be a conversation with your audiologist to make an adjustment. They'll take them out, he'll stick them back in the holder and adjust the computer settings and try it again. So there is a sort of empirical trial and error process, and then you will go off with them if you have good audiologic care. You might go off with them for 2 or 3 weeks and come back because, John, they're not just right. Well, what's going on? Well, I can hear this, but then I have trouble with it. Well, let's see if we can make an adjustment. And some of that also is around getting the right kind of what we might call hearing rehabilitation. If you've got a good audio, like, how do I use these things most effectively? And so give me some strategies. And you're not going to get that when you buy these over the counter.
Because I think some people think that audiologists don't have a role while you buy those things in Costco, and I totally agree with you that there are a lot of needs that can be met using a professional in getting those hearing aids. Thank you so much, and we'll see you in the fall.
Look forward to it.
Bye.